Thank you everyone for joining today. First, I'll be doing a welcome and an introduction for our speakers. Then we'll have a short breakout session where we will consider several questions related to a case study about culture of safety. And then we'll come back together again for discussion. First, we'll hear a few remarks from Jonathan Merrill, who is the Acting Deputy Director for Quality Health Care for the Indian Health Service. Also, we have staff from CMS and IHS on the line for this quick announcement. Jonathan, please go ahead.
Excellent. Thank you very much. I want to thank each and every one of you for your continued hard work in improving the health and well-being of the people we serve in the Indian Health Service and in Indian country. And thank you for being with us for the second session around creating a culture of safety. As we've said for many, many times, and well-referenced quote is that the purposeful introduction of structure and methods changes the culture of our organizations. And as we learn from the experts in the field through this Learning and Action Network, we create and build our capabilities and improve our ability to change that culture intentionally. There's other sayings in quality improvement that aims create systems and systems that generate those results. Over the past 2 years through our partnership with PATH, we have worked to lay out the foundation for ongoing, robust quality improvement. We want to add to the work by identifying a measurable aim that we can all get behind and generate measurable results as a system of care. We listen to you and we review the work that is occurring as we hear that there are 3 key areas which, if we made significant progress, we would dramatically improve. One of those is reduction in all-cause harm, facility-wide equality improvement, and transitions of care in our emergency departments. We have composed the following aims that encompass these 3 areas. In partnership, we will achieve a 20% reduction in all-cause harm, a 12% reduction in readmissions, and ensure 100% of our facilities have robust quality assurance performance improvement or QAPI programs, and that 95% of our patient care transitions in all service units to include discharge from the emergency department will be efficient and holistic by July 2019. My request is that you commit to achieving these aims and work closely with the PATH team so we can accomplish this crucial work. I want to thank each and every one of you for your continued participation, your dedication, and remember it's our mission and the people we serve that make IHS great. And I truly understand that and truly thank each and every one of you. And with that, I'll let us turn over to our experts and sign off from here.
Great, thank you, Jonathan. We appreciate your attending the LAN and giving us those remarks about the aims. I'd like to take a quick moment to introduce you to the PATH team, who is serving as your host today, and to whom you can reach out with any questions throughout our session. I'm your facilitator for today, Margaret White, along with Francesca Flores. You can find us in chat and the participant list, and you can chat to us privately, or you can chat to the whole group by choosing everyone on the chat list. That is also the best way to give us any questions you have for our speaker to answer at the end of the session. I'd like to welcome back Dr. Ronald Wyatt, who is the Chief Quality Officer at Cook County Health and Hospitals, one of the largest public health systems in the U.S. He's the Chief Quality Officer at Cook County Health and has over 30 years of experience as a clinician with extensive experience in promoting healthcare quality and patient safety in that system at the institutional and the organizational level. He currently serves as co-chair of the IHI Institute for Healthcare Improvement Equity Advisory Group. He presents nationally and internationally on leadership, safety culture, human factors in healthcare, patient experience, and health equity. Dr. Wyatt, I will turn it over to you.
So much, Margaret, and once again, good day, and thank you for your participation. It's really appreciated. Welcome again. I want to also express thanks to Rebecca and Francesca from the team, as well as the entire Health Insight New Mexico team that has really worked hard with me over the last few weeks to come back to visit with you again. So we can get started then. If I go to the next slide. So what we're going to do in this time we have is talk about leadership, and then spend some time talking about something that was just mentioned. That's how we began to think about in organizations, how we began to measure cultures inside organizations. And in fact, to show you examples of how safety culture is in fact measurable. I think let's start with leadership. And this is a quote from Paul O'Neill, who was at one point U.S. Secretary Treasurer, and then he was CEO of Alcoa. And what Paul says, and he's just a real champion of safety culture, particularly as it relates to the workforce. And what Paul says, I think is true, is that as leaders, we're responsible for everything in an organization, but then we become particularly responsible when something goes wrong. And I think we have to begin as leaders to think about that word responsible in a different way. And for me, as a leader, that says, am I able to respond? So as we go through this, let's think about what are our capabilities and are we able to respond in the organization when things go right as well as when they go wrong. So next slide. So let's start with the definition then of just what is leadership. And this is a definition we'll start with, and it's how leaders influence those around us to achieve a goal. And you just heard some of the goals that have been laid out for your system. And then we think through this a bit more, and I'll go back to Edgar Schein, who wrote a book called Humble Leadership. And what Edgar is now saying is, as leaders, we must begin to evolve our thinking about what that means. And as we do that, we're moving more towards how we are members of a team and how we team as leaders to achieve the goals that we set out for ourselves. So next slide. Then, so what does leadership look like? What are the behaviors that we need to think about how to focus on? And here's a list of about 5 to begin our thinking. We have to be person-centered. That's in word and in deed. So what that means then is, at a minimum, as leaders, we walk the walk, and we'll build on that as we go. Then you have to be engaged at the front line where care is being delivered, being an authentic presence. And this is something that Edgar Schein talks about for leaders to develop the skill of being present, being authentic, being genuine, and being visible in the organization. Having a undistracted focus on the vision and on the strategy that's been agreed upon by the organization. We're increasingly in a world that demands transparency. So as leaders, we begin to think about how are we more transparent in our results, in our progress, and our aims, as well as in our defects. So we need to understand more about how we begin to communicate out what we want people to know about our organizations and our leadership. And then being boundarylessness. So the old way is, how do we get out of the box? So that's looking at our organizations in a different way. That's beginning to have true systems engineering thinking. We collaborate across boundaries. So as leaders, then we have to start thinking about not solely focusing on the things we know about, but what is also called the unknown unknowns. And that's where system thinking will add value and pay off in those results that you just heard about that we're all driven to acquire. So next slide. And then as we think again through a system, and back to Paul O'Neill, who says, as leaders, we need to think about being excellent or not, and there's no in between. So then as we start to build systems of excellence, the role that leaderships play with the improvement team, back to that word, is in this system where we design, deploy, and sustain as a part of the teams that you see here, then where leadership really has to focus a lot of the effort is around the design and the deployment of the strategies. And that means as a team that we begin to co-produce on what we intend to deliver based on our strategies and our aims. Next slide. So this is the work from W. Demings. Many of you may know the name and know his history. And he talks about, again, a system, what he calls profound knowledge. And they all work in conjunction with each other. They can't be split out, but we'll focus on, for a minute, the appreciation for a system. So next slide. So then the components of appreciating a system is to not look at that system in a linear way, but begin to look at it in a non-linear way. What are all of the other activities and interactions between items and people and resources and products and processes and structures that will get us to that aim and the results that we desire? That we look at the system and those processes on a continuous basis. As leaders, getting back to the co-production, the co-design, the deployment, realizing that every system is perfectly designed to achieve exactly the results that it gets. So that's why leadership is so critical in being involved in the design of the system. Understanding that each part of the system has to work together as a whole and not as separate pieces. And that way we get to more effective outcomes, more efficient outcomes, a better value, and frankly, more satisfaction in the work that we are called to do. And then understand that people are a key part of that system, that people come up and want to do a good job. People want to take pride in their work. So we have to work in a culture, think about what is in that culture that's inefficient, that's leading to lower levels of morale and loss of joy in the workplace. Next slide. So then as leaders, and this driver diagram lays out leading and managing again in a system of excellence. So then leading means you're at that front line with the teams, that you're functionally involved with the work that's taking place at the front line. You're involved with managing the work, improving the work, building team capability, and then shaping that team culture. Next slide. So then there's this interplay between what leaders need on a team and leadership skills and the management skills. So if we go down the management skills side, it's how we allocate resources, budget, staffing, how we measure, which we'll talk about a bit later. And we have to deal with hiring and firing, directing, supervising, ordering, and improving. Then as leaders, the skills we look at is, are you living that vision? Are you articulating that vision? Do you practice and engage in strategic thinking? And are you building teams in a way that's going to be spreadable and sustainable over time? And then the most important one I think of all is to communicate, communicate, communicate. So as I said earlier, we talked about as leaders, how we walk the walk. The other three parts to that is how we walk that talk, how we talk that walk, and how we talk that talk. So communicating on a constant basis, prioritizing around our strategic aims, how we begin to enable, and I would say as leaders going beyond how we enable teams, but how teams truly become activated. And for that to happen, as leaders, we need to be that role model for the organization to achieve higher levels of a safety culture. Next slide. So this is a picture of my boss when I was in Doha, Dr. Hanan, who is standing in front of the board. The gentleman with the hand on his chin is the CEO of the heart hospital at the Hamad Medical Corporation. I assure you, it's not a look of fear or shock that he has, but extreme pride. So a day before, Dr. Hanan asked me, called me and said, pick a hospital, let's go to the hospital. I want to see the good, I want to hear the bad. So don't tell them we're coming, but let's go and pick a unit and go to that unit. So we walked into the hospital and I said, we're going to go visit with Gracie. And Hamad is a 10 hospital system. And I regularly visited all of those organizations. So I said, let's go visit with Gracie. And we walked up on the floor, and by then, you know that the Minister of Health for Qatar is on the floor. So I said, Gracie, I want you to go over to your improvement board and tell Dr. Hanan what's happening on this unit. This was a cold call, and you can see here where Grace was able to go to that board, show Dr. Hanan where we were in that organization around their value improvement, what was working, what was being improved on, and again, back to the intro at the beginning, in quantifiable, measurable ways, how far we were along to achieving our aims. So situational awareness is really important for leadership and team work and building a culture of safety. Next slide. So now as we begin to think about measurement, I want to revisit for a second the principles of just culture, recognizing that there are three major components, and this comes from the work of James Reasons as well as David Marks. First, there's human error, and that's that inadvertent slip or lapse. And as you read through that, that's a human error, and that's to be expected. Those individuals involved in that then are counseled. If it's at-risk behavior, that means that a person chose a particular action without realizing the risk of an unintended outcome. So then we work through how we handle a situation like that and improve the system if that's necessary. And then if there's reckless or negligent behavior, that means when a person chooses an action with the knowledge that is a conscious disregard for the risk of harm, and you've accepted that risk that can end up in harm. In that case, we think through how we apply disciplinary action. Next slide. So then keeping that in mind, one important part of a safety culture and what we call a just culture is that not only do we lead in that culture, but we also reward in that culture. So that means as leaders, we must possess a thorough understanding of the principles that we just outlined, as well as maintaining situational awareness in the system that we lead. Commit to teaching, commit to modeling the kind of culture that we want to accomplish in our system, in our organization. Focus on systems issues. Leaders, how errors and harm are a result of systems-related failures, violations, slips, lapses, organizational issues such as staffing, equipment-related issues. Then it's this holding clinicians and the rest of the workforce then accountable if there are less than expected outcomes that result from disregard of established protocols and procedures. It's extremely important as organizations approach a true safety culture and a just culture that we begin to report. Errors, lapses, near misses, adverse events should be encouraged by leadership and rewarded by leadership. Then leaders support the workforce when the system does break down, when errors do occur. What was the system-related contribution and how can we go about mitigating those risks? Empowering, activating workforce members. This is clinical and non-clinical. Don't ignore the entire organization. That's from environmental services to building and grounds to facilities through the clinical services and workforce. And everyone should be empowered. Everyone should be courageous in speaking up and voicing concerns, pointing out unsafe conditions, communicating threats to patients and the rest of the workforce. Next slide. So then as we began to develop safety leaders, let's start to think about what needs to be in place and how can we begin to measure, as was talked about earlier. So the next two slides are borrowed from Leading a Culture of Safety, a Blueprint for Success, that I would encourage all of you to download. It's a wonderful publication that came from the American Hospital Association and the National Patient Safety Foundation. So I'm going to give you some abbreviated ideas to think about as leaders. First, let's develop safety leaders in the organization. Define what those competencies are. Define what those processes need to be at all levels. Provide resources through educational opportunities, especially safety culture and safety science. Begin to develop systems for coaching, for training, for improving, for mentoring, both current as well as prospective leaders. Provide opportunities for teamwork in that training, for interdisciplinary, interprofessional training, and then providing opportunities for learning from organizations outside of our organization. Look to other industries, railroads, zoos, aviation. They're all examples of how safety culture can be applied in our organizations. Next slide. So then as we think about just simple yes or no's, as we begin to think about how to measure, and in the publication I referenced, there's a more robust plan on how to measure, but just ask, you can start with just yes or no questions. Are we receiving safety science training and safety culture training? Is there at least one member on the executive leadership team that is a safety expert who is formally trained? Are leadership development plans reviewed on an annual basis, not every few years? And do they include measures on key safety culture competencies that have been agreed upon by the organization? The leadership development programs include a robust skill set in communication, in engagement, in how to listen, and I would say humbly listen. Is there performance improvement built in around emotional intelligence as well as adaptive intelligence? And then recognizing that we all as leaders need some level of business acumen. Next slide. So the next area to look at, and we refer to, is, are we leading and rewarding in this safety culture? Do we have a just culture policy that aligns across all the systems and departments? Is the board educated around safety culture, the leadership and the workforce all educated? Are those culture principles in effect when we do an event analysis? Is it part of how decisions are made, corrective actions are established? How do we begin to be more transparent? As I said, we're in a culture now where from CMS to accreditation organizations, is how are we beginning to be more transparent around our data, our errors, and decisions we make that benefit the public? Are we identifying gaps in the culture and recognizing adverse events? Do we have metrics? We need to develop metrics for a just culture and then hold the workforce accountable, particularly as it relates to unprofessional behavior. Next slide. So simple, again, yes or no questions with leading and rewarding. Do board leadership, workforce, all have programs that include training and just culture? Is there a set of defined behavioral expectations for all individuals in that organization? Is compliance with established just culture framework a part of a regular review, a regular performance review? And this must include career development plans for all the leaders in the workforce. Does the organization use, evaluate, and define action plans? And again, these are quantifiable action plans. That means numerator and denominator data related to measures of just culture on our employee surveys. Is there an existing measure that's regularly evaluated for assessing frontline knowledge of a just culture algorithm or unsafe culture algorithm, whichever one we as organizations decide to adopt? Next slide. So then critical is, as leaders, we begin to address behavior and behavior expectations and unprofessional behavior in the organization, or the entire workforce, clinicians and non-clinicians, held to the same level as relates to behaviors. So that means then we need to develop organization-wide processes and explain what the expected behaviors are. Define how we respond in the organization if there is unprofessional or disrespectful behavior. Encourage open reporting, safety discussions, and provide feedback across the organizations when we address these issues. Hold all leaders and the workforce accountable, as we talked about. Recognize and reward the workforce that's engaged in these safety behaviors, and engage patients, having patient advisory councils, et cetera, on the team as we begin to communicate what we plan to accomplish in this organization. Next slide. So simple questions then: does the organization have a clearly defined reporting system? Are organizational behavior expectations such as huddles and briefings and follow-up plans implemented and reviewed on a regular basis? Are professional accountability standards in place and used and also regularly evaluated? Are there tools being used to encourage teamwork and clear communications in place? This could be SBAR, it could be team steps, it could be crew resource management, but have some method to practice and encourage teamwork and more clarity around communications. And then is there communications and resolution, reconciliation programs in place, and are they used and evaluated on an ongoing way? Next slide. So then if we start to think about the stages that we move through as organizations as we want to become more high reliability organizations, what we want to accomplish is zero error, zero harm as a choice. And when we look at how to get there, when we approach this, next slide. So we begin to think of safety culture being in place, that is measured. There are strategic metrics that are reported to the board. There's systematic improvement initiatives underway to achieve a fully functioning safety culture. Next slide. So then what should this culture look like? We're moving from cost-based quality to value-based. We must have a relentless pursuit of process efficiency and effectiveness, achieving excellence. Then we have to have a better understanding of system-wide performance improvement. This could be Six Sigma-like programs, the Model for Improvement, PDSA, whatever approach you decide as an organization to adopt. Then is how we optimize the system around these processes through multifunctional improvements. not project by project by project, but as system-wide initiatives, enterprise-wide assurance systems that measure and maintain daily control. Working closely with finance as we improve quality in the organization and this safety culture throughout the workforce. Training the workforce in quality assurance, in quality control, and in quality improvement. Having annual and biannual programs that renew themselves, that are aimed at performance improvement, and that's the sustainability part. So we build capacity, we build capability, we spread, and then we implement and we sustain. Next slide. So in the end, and I won't read through this, but the last line, which says that once we get to this place of excellence and safety culture in our organizations, as leaders, we look back and we're not saying I did it, it's that we did it. As a team, we did this, and we can say that to ourselves to the point that in a true safety culture, we no longer talk about how things used to be, but what we've been able to accomplish. So I will pause there, and I thank you so much for taking the time to listen to me.
Thank you, Dr. Wyatt. I think we had just one more slide where you might have wanted to talk about a publication.
So this is the publication that I referenced, Leading a Culture of Safety, a Blueprint for Success. It has a more robust measurement plan that I would encourage you in your time to take a look at that and how you can build that into your organizations as you begin to measure your culture of safety. Thank you.
Thank you, Dr. Wyatt. So next we're going to be moving into our breakout rooms, but before we do that, we have a case study that we're actually going to be looking at in each of the breakout rooms. And I'm just going to take a quick few minutes to read through the case study, and then we'll move you to your breakout rooms. So Mr. Williams is a previously healthy 58-year-old man with a recent history of shortness of breath when he exercises. He's been referred by his primary care physician for a cardiology consultation, and a stress test is ordered. The results of the stress test indicate a positive finding for potential heart disease. These results are not communicated back to his primary care provider. The results were sent to the referring cardiologist, but she is away at a conference. Mr. Williams receives no communications about the results of his test. 1 week later, Mr. Williams presents to the emergency department with chest pain and is diagnosed with an acute myocardial infarction. Upon further review of his medical records, the care team reviews his past test results and learns about the positive stress test. Mr. Williams requires placement of a stent to open his coronary artery and requires rehabilitation prior to discharge to his home due to reduced cardiac function. 1 week after the discharge from inpatient rehabilitation, Mr. Williams returns to his primary care physician, who realizes that Mr. Williams is not taking one of his new cardiac medications that was ordered by his inpatient team. Great, now we're gonna check in with facilitators from our breakout rooms. Do we have a facilitator from room 1?
Yeah, this is Lori. I can kick it off and get it started. So some of the things we talked about is the lack of communication between the primary care physician when he ordered the referral, and making sure he has that physician has a system in place to monitor the results of that stress test. Let's see, we also talked about having a system in place when the cardiologist is not available for the results of that stress test. Let's see, we talked about finding a solution and the root cause to the problem, and different ways to set up policies or specific people assigned to monitor the test results. And overall, closing the loop on those referrals and making sure that the primary care physician is following up on the referrals.
Yeah, and this is Carrie. One of the things that we were talking about towards the end of our conversation too was the patient himself. So, you know, obviously a lot of process issues and things, opportunities for improvement with the communication within the facility. But then the last piece of the case study is that one of the medications that he had been prescribed he wasn't taking. So we talked a little bit about that patient and family engagement, and how do we talk with that patient about, you know, why he may not be taking it. Maybe he doesn't really understand what it is or what it's for. Somebody also mentioned it could be a financial burden. So again, you know, maybe he didn't fill the prescription because he couldn't afford it, and what are the other alternatives that we can prescribe. So we spent a little bit of time talking about that as well.
So those are really good points, and I'll make up a couple of additions to that. So when you think about that, we have to look through the eyes of the patient. Now, a couple of things really important. Did the patient lose trust in us? And is that why he doesn't have the medications? The other thing, a good point is, if he could not afford it, we tend to overlook a patient's dignity. And sometimes patients just don't want to talk about that because it's part of their dignity. So we have to look through ways as a team to train around how we show compassion, how we build trust, and how we help patients maintain their dignity when they come to see us.
That's a great point, Dr. Wyatt, is that trust in maintaining patient dignity. Room 2, are you available for giving us, just briefly share a few items from the discussion in your breakout room?
Sure. This is Mary, and I think the overall theme that came out, because all the answers that we had good discussion and they were great ideas that were put forth, but I think I keep going back to the slide where Dr. Wyatt talked about communication, and from the beginning, when the patient was first in the door, and the information to the patient, and then communicating to each other, the care coordination piece. And I just think that theme right there is what is being communicated to whom and when. Natasha, do you want to add anything to that?
Yeah, I think you hit it perfectly. I think communication, and the team was really focused on getting to that root cause and understanding what the issue was and resolving it as soon as possible. And then how do you take that next step to going to, you know, talking about those just culture models? How do we go from finding the issue to really having a solution that'll fit everyone and fit the entire facility, and of course involve the patient in that?
Great, thanks for sharing about your discussion in room 2. I wanted to just take a moment and ask if there was a group, maybe one of the facilities that's meeting in a group, and their PATH PM might want to share out some of their discussions, or if you wanted to put something in chat. And in the meantime, where we're waiting for people maybe to put in questions in chat, or for one of the facilities to share, Dr. Wyatt, I noticed that in chat you had put that this is heart work and not hard work. Did you want to expand on that?
I do. I think again, it gets back to that theme of when patients come to us, they want to trust us. They want to see and feel empathy. They want to see and feel compassion. They want to be able to communicate to us from their perspective what matters to them. And we have to pull ourselves up out of that and just humbly listen to what the patients are trying to tell us, and then to respond appropriately. So how do we do that? It's been summed up by first saying we have to love our patients. We have to love our team. We have to love the community that is trusting us. And all quality improvement work begins with that simple 4 letters, LOVE. Everything else builds off of that. It becomes work of the heart. It's not as difficult when we see the system from that perspective, and we can build on that. We can spread that, and we can sustain that. So I would encourage, out of all of the other things we talk about, if we root ourselves in those things, which is, you know, listen to me, speak with me, don't hurt me, don't make me wait, don't waste my time, apologize to me. And if we build on those, you know, then we can truly transform a system that becomes a safety culture, because it becomes an epidemic when we build that kind of culture.
Great, thank you. And I see in chat people are agreeing with you positively on that. type of message to the patient, and that we just need to communicate and over communicate and engage the patient and make sure they understand things like their discharge plan. And maybe that might have been one of the reasons Mr. Williams didn't know about his additional medication. We have a few minutes left. Was there a facility that wanted to share their discussion either via audio or on chat? Not hearing anything. Dr. Wyatt, I invite you to maybe just give us some takeaway themes, or maybe some takeaway action items for us to go back to our facilities and work with our staff and our patients.
Sure, I'll just say that we all go back to our organizations and just be leaders. And a leader is a part of a team. And that means that everyone in that organization is a leader, and that the bold aim is that we become excellent, not average, not status quo, not what's acceptable, but the aim is to be excellent, and that we can measure that excellence in our culture through the metrics that we all agree upon. So open communication, visible, powerful, courageous leadership. That doesn't mean just sharing the good news, but talking about where we have challenges and opportunities in that organization. We know that we don't over rely on policy or technology, but on each other. So we can take that back as leaders. Again, we begin to build more resilient organizations that are always aware of what could happen in the organization, that we're always on the lookout for where we can remove risk and make patient care safer, help the workforce be happier and more joyful, and that we get better outcomes for our patients, their families, and our communities.
And again, I want to thank Dr. Wyatt for his participation and his time. And we appreciate everyone attending today with their time. And I want to wish you a very good day. Thank you very much.